Gastric acidity. There seems certainly to be a link between gastric acidity and infection with V. cholera. In the outbreak in Italy in 1973, no fewer than 24 of 70 cholera patients had previously had a partial gastrictomy. Of 30 of the others who were investigated, 14 had a chlorhydria and 14 had hypochlorhydria. Of the remaining 16, most of them were elderly or had some other illness which might have impaired gastric secretion. It has been said that in patients with low or absent gastric acidity with incubation, a period may be shorter. Another disease more severe than in normal patients, but obviously in a disease so variable in its severity and in its incubation period, it would need careful study um, to establish these points. The connection between gastric acidity and infection had been shown in human volunteer experiments. It appears to be quite difficult to infect normal person. He must be given a dose of at least 10 to the power 11 organisms, but if he first swallows 2 grams of sodium bicarbonate, then 10 to the power 6 organisms are enough. One of the first cases in the Portugal 1974 outbreak was in a man who took antacids regularly, but it is not known how many vibrous he swallowed. Patrick Coffer and Emerge both experimented on themselves by first swallowing bicarbonate and then a dose of Vibrio in water. Patrick Coffer had some diarrhea, but Emerge had severe cholera with loss of voice and temporary anorexia. The experiment was obviously a hazardous one, among other things. It illustrates how difficult it can be to forecast the outcome or severity of infection with V. cholera. Even in a famous hygienist in an investigation in West Bengal, 16 of 39 patients with cholera were found to be hypochlorhydria. Their gastric juice did not kill cholera vibrous in vitro, whereas the gastric juice of patients with normal gastric acidity did. When American volunteers in the same investigation were given bicarbonate and cholera vibrous by mouth, the resulting infection did not cause hypochlorhydria, but any volunteer with low basal or postprandial gastric acid before infection had a more severe diarrheal attack than those with normal acidity. It seemed clear, therefore, that cholera did not lower gastric acidity in patients, effect that the outcome of infection with cholera. Hypochlorhydria appears to be fairly common in West Bengal, especially in Vibrous. In estuary and other surface waters may not be high. Not high enough to infect people with normal gastric acidity, but high enough of infect those with low gastric acidity. This may be one of the reasons why cholera can persist as an endemic area and in its epidemic period gets into cleaner water or into food where it can multiply. The dose of swallowed vibrous may be much higher, and this may cancel out any differences in susceptibility between child and adult or between those with loss or normal gastric acidity. Carriers of the cholera have been classified rather illogically into incubatory, convalescent, symptomatic, and chronic, but only the last two are truly carriers. The other two are in the early and the recovery stages of the disease. The incubation period, in short, so that an incubatory carrier excretes for only 1 to 5 days, convalescent carriers for 2 to 3 weeks. Asymptomatic carriers have usually been detected as family contacts of a patient and are said to excrete for between 5 days to 2 weeks or a little more. Okay.